Hello everyone and welcome to Blood and Hematology YouTube channel. This video is about erythrocyte indices. MCV, MCH, and MCHC were first introduced by Dr. Maxwell Meyer Wintrobe in 1929 to define the size and hemoglobin content and concentration of red blood cells. Red cell indices, also known as Wintrobe's indices, could be used clinically if precise measurements of erythrocyte count, hematocrit, and hemoglobin were made. Red cell indices, based on population averages, are useful for initial classification and differential diagnosis of anemias. They also provide stable measurements for internal quality control of counting instruments. With the general availability of electronic cell counters, red cell indices are now automatically measured in all blood count determinations. Some red cell parameters are directly measured, while others are derived from these primary measurements. Red cell indices are average quantities and therefore may not detect abnormalities in blood with mixed cell populations. The mean cell volume, or MCV, is the average volume of the red blood cell, expressed in femtoliters. MCV can be calculated by dividing the hematocrit by the RBC count, with a reference interval of 80 to 100 femtoliters. Automated blood counters measure the MCV directly by either electrical impedance or light scatter measurements of individual red cells. The MCV reflects RBC diameter on a stained blood smear. The MCV has been used to guide the diagnostic workup in patients with anemia. Erythrocytes with an MCV of less than 80 femtoliters are microcytic, and those with an MCV of more than 100 femtoliters are macrocytic. This approach has practical value, but also limitations. In situations such as sideroblastic anemia, recently transfused patients, severe pernicious anemia with red cell fragmentation, and folate plus iron deficiency, both large and small red cells are present, diminishing the value of the MCV. Beckman-Coulter introduced mean SVID corpuscular volume as a way to measure erythrocyte volume in hypoosmotic solutions. Low MSCV has been demonstrated to be a sensitive parameter for hereditary spherocytosis detection. When expressed as delta MSCV, the difference between MCV and MSCV, this measurement has even higher discriminatory value for the detection of hereditary spherocytosis, which is confirmed by increased delta MSCV. The red cell distribution width is calculated directly from the erythrocyte volume distribution histogram and is reported statistically as coefficient of variation and standard deviation. RDWCV represents the coefficient of variation of erythrocyte volume around MCV, with a reference interval of 11.5 to 14.5%. RDWSD is determined from the width of erythrocyte volume distribution curve, at level 20% above baseline, with a reference interval of 37 to 54 femtoliters. The RDW is an index of anisocytosis. MCV and RDW are used by the instrument to flag possible anisocytosis, microcytes, and macrocytosis. An RDW greater than 14.5% indicates a heterogeneous population of erythrocytes. A low RDW is of no significance. The RDW is markedly elevated in newborns, with a range of 15.5 to 20% at birth, which gradually decreasing until it reaches adult levels by 6 months of age. The figure demonstrates anisocytosis, macrocytes, and a polychromatic erythrocyte in peripheral blood from a neonate. The mean cell hemoglobin is the average weight of hemoglobin in a single red blood cell, expressed in picograms. MCH can be calculated by dividing the hemoglobin by the RBC count, with a reference interval of 26 to 34 picograms. The MCH changes in parallel with the MCV, and generally provides similar diagnostic information. The mean cell hemoglobin concentration is the average concentration of hemoglobin in each individual red blood cell, expressed in grams per deciliter. MCHC can be calculated by dividing the hemoglobin by the hematocrit, with a reference interval of 32 to 36 grams per deciliter. The MCHC reflects erythrocyte staining intensity and amount of central pallor. The MCHC is not used much diagnostically, and is primarily useful for quality control purposes, such as detecting sample turbidity. If the MCHC is within the reference interval, the erythrocytes are considered normal or normochromic and display typical central pallor of 1/3 the volume of the cell. If the MCHC is less than the reference interval, the erythrocytes are called hyperchromic. This correlates with a larger central pallor when the cells are examined on a stained blood smear. Values of hyperchromic erythrocytes are greater than 36 grams per deciliter. The term hyperchromic is a misnomer. An erythrocyte does not really contain more than 36 grams per deciliter of hemoglobin, but its shape may have become spherocytic, which makes the erythrocyte appear full. Therefore, an MCHC between 36 and 38 grams per deciliter should be checked for spherocytes. Interferences with the hemoglobin colorimetric method, such as hemolysis, lipemia, or icterus, affect the calculated MCHC. Therefore, an MCHC greater than 38 grams per deciliter should be investigated for an error in hemoglobin value. Another cause for a markedly increased MCHC could be the presence of a cold agglutinin. Incubating the blood sample at 37 degrees Celsius for 15 to 30 minutes before analysis usually produces accurate results. The cell hemoglobin concentration mean indicates the average of a direct optically measured hemoglobin concentration within individual erythrocytes by flow cytometry. The CHCM can be considered the optical equivalent of the MCHC of intact red cells. CHCM generally is not reported as a patient result, but is used by the instrument as an internal check for the MCHC. CHCM is not subject to interference from the free plasma hemoglobin. Interferences with the hemoglobin colorimetric method affect the calculated MCHC but do not alter measured CHCM. Calculation of the difference between MCHC and CHCM provides an accurate quantification of the degree of hemolysis in a given sample. The hemoglobin distribution width is calculated as the standard deviation of the RBC hemoglobin concentration histogram. The reference interval for HDW is 2.2 to 3.2 grams per deciliter. The HDW, initially determined optically with the use of a laser, measures heterogeneity in the hemoglobin concentration between individual erythrocytes and correlates with anisochromasia apparent in blood smear. Thank you for watching this video. If you liked this video, to give it a thumbs up and share it. Do not forget to subscribe to the channel, if you still have not. You can click on the bell to receive notifications whenever a new video is uploaded.